I wanted to do here is you've heard a lot today about where melanoma is in the current state of the field. And what this panel and hopefully a good discussion is going to do is kind of taking us beyond 2020 and talking about some of the treatments that are currently in clinical trial that are showing a lot of promise and kind of moving the field forward. Yeah.
Yeah, it worked.
Oh, there we go. Hold on, did I? Okay, yes. All right. So again, you've heard a lot today about some of the success of the therapies really just over the last decade. But I will say that there's still room for improvement. And I want to frame a little bit about why I think we haven't won yet. First and foremost, not all melanomas are created equal. So even two patients showing up with the same skin melanoma, the same thickness on the same day, may have very drastic different courses. And again, we are learning more and more about why not all melanomas are created equal. This is particularly true for the rare subtypes. Again, like you heard Cody say, I see primarily the rare subtypes, so that's the ocular melanomas, uveal melanoma, conjunctival melanoma, mucosal melanoma, acromelanoma. They definitely behave and respond differently to the current available treatments, including targeted therapy and immune checkpoint therapy, and really still, I think, have a higher mountain to climb today. And again, even in cutaneous melanoma, not all patients are responding. If they do respond, resistance can develop. So certainly there's a need to try to make duration of response better. And then embedded in all of the subtypes of melanoma are really what we call the difficult to treat populations and scenarios. And this includes brain metastasis as well as liver metastasis. So again, I just want to highlight that it's really important to know that cutaneous is not uveal, which is not conjunctival, which is actually a more rare subtype of ocular melanoma, which is not mucosal. And forgive me, there should be a column also on acromelanoma. But really you can glance this over, but incidence is different, cause is different, mutations that drive them are different, primary management's different, how we risk prognosticate and predict who may recur is different. The percent of patients that are metastatic at presentation is different, and then certainly treatment is different. So, even though melanomas may look the same under a microscope, when you get, when a physician gets the pathology report and it says metastatic melanoma or melanoma, it's really important to know where this is coming from because how we approach it, the clinical trials that we may assign somebody to, it can be very, very different. So, interestingly, this was a publication not so distant past in 2016 that actually looked at overall survival for all of the subtypes. So mucosal, acral, non-acral cutaneous, which is ultimately cutaneous, unknown, and uveal. And this could arguably be a little bit dated and maybe doesn't really incorporate the full effect of the change in which we treat melanoma with immune checkpoints and targeted therapy. But here you can see that probability of overall survival out 72 months is definitely not where it needs to be. Here, uveal being the purple line at the bottom, and actually melanoma of unknown primary being somewhat there, kind of at the top. But at the end of the day, we can certainly do better. But why should we still be so excited? Again, you heard a lot about the treatments today. I just want to remind you that this was an overall survival curve from ipilimumab alone. And this was 10 years out. So patients who responded to ipilimumab alone, you could kind of see this tail of the curve. And these patients were still alive at 10 years. So it is possible. We just need to take this bar and put it closer up to that 1.0 up there. But again, I like to incorporate the slide because I think it's just a reminder of why we got so excited in the beginning and why we need to continue to fuel that excitement. So just a reminder, you may have heard some of this today. Again, in cutaneous melanoma, we're doing, quite well. However, not all patients are responding. So this is from what we call the Checkmate 067 study, which looked at nivolumab versus the combination of IPI and nivo versus IPI. And even though we have about 57% of patients responding to the combination, that's still about 43% of patients without response. So there's still almost half of patients who are not getting any benefit from what is currently, the standard of care. So again, room for improvement. Similar in targeted therapy, this is just a quick snapshot of one of the more recent trials, just showing that there is a portion of patients who are responding and surviving, but we can certainly move those lines up. And again, hopefully today here on the panel, you'll hear some ideas about how we're trying to make that happen. Again, that's mostly cutaneous melanoma. In uveal melanoma, which is melanoma I treat predominantly, we have more room to go. You can see there some response rates for some of the immunotherapies are somewhere in the single digits. Ipi-Nivo looking around 12-ish% and maybe 15%. So not as good as cutaneous melanoma, where we're seeing it more in the 50+%. So room for improvement there. Targeted therapy in uveal melanoma has been also quite poor, so it's a little more complicated than just the BRAF story in uveal melanoma. We know there's a mutation in something called GNAQ, GNA11, and we've tried to target lots of different things downstream, but you can see a lot of these attempts, we're looking at response rates of 0%, 5%, 3%. There was an effort with MEK inhibitor, selumetinib, but subsequent studies didn't completely pan out. So there are some current trials ongoing in uveal melanoma using different inhibitors, trying to target different things, but again, still much more room for improvement. For mucosal melanoma, certainly immunotherapy is better than it is in uveal melanoma, but you can see kind of across the top, for you look at nivolumab monotherapy in mucosal versus cutaneous, response rates of 23 versus 40. Combination, we're looking at 37 versus 60, and here IPI 8 versus 21. So again, immunotherapy is working in mucosal, but we can certainly do better. Targeted therapy in mucosal, a little more complicated. We do see BRAF and KIT mutations, but because mucosal melanoma is kind of actually, mucosal melanoma under the umbrella can be very different. You can have vulvovaginal, sinonasal, anorectal, and all of these can behave differently as well. We see the KIT mutations being different, so targeting it with one drug still can be quite difficult. And again, the two kind of special populations, brain metastasis, still a very high unmet need. So close to half of all patients, I should say really cutaneous melanoma, may encounter brain metastasis at some point during their disease course. It's a major cause of morbidity and mortality. And sometimes patients at first presentation may need steroids because of the swelling, and that can impact the ability to use immunotherapy. And we've shown that intracranial response to treatments, notably for symptomatic brain mets, is inferior to kind of how patients respond from the chin down. So if patients are asymptomatic, they may actually respond better, but if they're already having symptoms at the time, sometimes it's hard to really get a response in the brain with immunotherapy. So that's still a high unmet need. And then liver metastasis. And liver metastasis certainly is a major issue for uveal melanoma, but it is an issue in other subtypes. Liver metastasis, regardless of subtype, may have a less response to immunotherapy. And in uveal melanoma, things like liver-directed therapies and combination systemic and liver-directed therapies are an option, but again, still a high unmet need. So without further ado, I'd like to invite the panel up here, Dr. Georgia Beasley from Duke, Dr. Ken Grossman from University of Utah, Dr. Stephanie Goff from the NCI, Dr. James Moon from University of Michigan, and Dr. Tony Rebus from UCLA. And like Cody mentioned, what we're going to do is I'm going to give kind of 5 minutes to each of the panelists to talk a little bit about their topic. And then we're really going to open it up to questions. This is really meant to be interactive. And I think we have about 45 minutes allocated for questions. So use that time.
We'll put you in the hot seat.
Remember, I realize the order up there is not the order that we're going through, but there we go. Okay. All right, no one else has slides, right?
No.
Okay.
No. Unscripted.
Okay, there we go.
So am I first? Make sure we've got, I am first.
Yes, you are good.
All right. Thanks everybody for your attention today. I've been asked to talk to you a little bit about combination strategies in melanoma, in particular triplet therapy as it relates to BRAF mutated melanoma. So first of all, why do we need triplets? Well, as I think was made clear in the previous presentation, many of our therapies are not hitting those long-term benchmarks. To summarize a few points, the dabrafenib trametinib 4 to 5 year progression-free survival sits right around 20%. And if you look at our PD-1 inhibitor trials, that same benchmark, 4 to 5 year survival, sits around 30 to 40%. So obviously we need to move those batting averages up. There are important mechanisms of resistance that we've learned about over many years, both to BRAF inhibitors and to PD-1 inhibitors. The BRAF story is actually a 1 hour lecture in and of itself. We've learned a lot about how BRAF becomes amplified, COT becomes amplified, crosstalk to the PI3 kinase pathway, loss of PTEN. The list goes on and on and on for why the cells become resistant. The PD-1 inhibitors also have their own kind of Achilles heel, so to speak. We understand that there's problems with targeting the T cell to the tumor. There's problems with a resistant microenvironment excluding the T cell. And then finally, at the last step where the T cell has to interact with and actually attack the tumor, there are problems with sort of the release of those tumoricidal factors that are necessary to complete the work. So all of this to say why we need triplets, and one good reason for that, we live in America, so more is better. Secondarily, we really think mechanistically those combinations make a lot of sense. So we learned this dating back many years to our use of the BRAF inhibitors, where we would treat patients with those drugs and notice that they would develop vitiligo. And we got very early signals that there would be an immune positive response to just the targeted therapy alone. Fast forward that story, we've now learned a lot about why that happens. Opens the microenvironment, improves our cytokine milieu, improves antigen presentation. So all those things that are happening on the BRAF inhibitors, it makes perfect sense of why you'd want to put immune therapy together with all of that. So we have some early data, and that's exciting. We've seen that in our combination studies where our response rates are well north of 80%, which is wonderful. Yet the durability of those responses in different settings are still not quite where we want them, and the maturity of that data is still forthcoming. So this is really an early wave of where we see those triplets going. To give you just some thumbnail numbers to sort of hang on to, I think a real important benchmark that we in the field are starting to understand as an early read is the 24-month progression-free survival for our patients. And looking at the triplets in comparison to just BRAF alone, it more or less doubles that rate from about 20% to 40%. So, and this is from the Keynote-022 trial that was just presented at the last SMR meeting in Salt Lake City. So I think with those remarks, I've probably consumed my 5 minutes, and I'm going to hand the reins to the next speaker.
Okay. Yep.
So I'm a surgeon at Duke University, and I'm going to be talking a little bit about adjuvant therapy and neoadjuvant therapy. So typically, adjuvant therapy is actually defined as additional cancer treatment after the primary treatment to lower the risk that the cancer comes back. So we usually think about that in the context of treatment after surgery to lower the chance of melanoma coming back. And I think the true value of adjuvant therapy is that we may be able to have a time when we can tell a patient, we never have to tell a patient that your cancer is back. And that's something that's really, really valuable and could be really powerful. So I think when we think of adjuvant therapy, I think of never having to tell someone that their cancer is back. So that's the value of adjuvant therapy. From a biologic perspective, treating patients at earlier stages kind of makes sense. If you have a lot of disease already in your liver and your lung, for example, you're asking that therapy to do a lot. There's a lot of cancer it has to kill. So climbing a mountain. If you're asking the therapy to treat maybe a few cells that are circulating that we can't see, that's a lot easier job that you're asking it to do. So that's climbing a hill, not a mountain. So thinking about adjuvant therapy is after we know all the disease is gone, at least that we can see or feel, using the therapy then is sort of climbing a hill instead of a mountain. So it may have a better chance of working. And so finally, the promise of this type of therapy is finally in clinical practice for some of our melanoma patients. And for patients that have melanoma either in their lymph nodes or spread maybe to one site, we can offer these therapies, which are the same ones that we use in the metastatic setting, both targeted therapies and checkpoint, as you heard. And if we give those therapies, we can reduce the chance of the cancer coming back by about 50% in those patients. So that's very, very important. They do have the same toxicities that we've heard a lot about, and so it's really the future direction is really trying to drill down who needs those adjuvant therapies. Because right now we have a pretty good idea, but we really need to drill that down because we certainly don't want to expose people to the potential toxicities if they're not going to benefit. And then we want to give it to people that it really will reduce their chance. And so when we think about adjuvant therapy, the future direction is really sorting out who really needs it. And so it's my job as a surgeon to make sure patients after surgery know who should get adjuvant therapy. But the next thing that I'm also excited about is neoadjuvant therapy. So that's where we would give the systemic therapy, treat the whole body before surgery. And there are a couple advantages to that. In other cancers, like breast cancer is a good example, you might be able to convert a woman that needed a lumpectomy or was going to need a mastectomy rather, so the whole breast removed. If you can shrink the tumor, then they may only need part of their breast removed. So that's just an example, and whether we can do that in a similar kind of thing in melanoma, where if we shrink the tumor, it may make the surgery a little bit easier. So that's one potential advantage to neoadjuvant therapy. The second one would be that, when the medical oncologist up here with me that I'm not going to pick on, they give the treatment, we don't really know if it's working, except we get CT scans and we look and see, is it smaller or bigger, but we don't really know what's happening to the biology of the tumor. If we give the therapy before surgery and then I remove it, the pathologist can look at the tumor and say, yes, this therapy worked, because it might be dead or a whole spectrum of it didn't work, so completely gone. And then we can say, gee, that therapy works for that patient really well, and so maybe we can think about continuing it. Or we say, look, this didn't really have any effect at all, and so maybe it's time to think about a different therapy for that patient. The second thing is that whether you give the therapy before or after surgery, the patient's whole body really needs treated when they have this type of advanced disease. So their whole body really needs treated, because even though I make a living off of surgery, I'm not impacting spread. I'm only treating my site. And so I think about neoadjuvant therapy. The patients really are going to need their whole body treated before or after surgery, and so there are some reasons to potentially try to do it before. Finally, the main risk, and I get it. When patients come to me, I'm the surgeon. They want it cut out, and I get it. The risk is that if we treat them with therapy, we may miss sort of a window, right? So what if it spreads before I take it out? And that's something that certainly is possible. So again, as the patient panel earlier, try to be honest with people, but the way we do it now is that myself, the surgeon, and the treating medical oncologist, we follow patients really closely. And the second it seems like it's not working, I take them to surgery. So even if they don't finish their planned, whatever the plan was, if it's not working, that's when we stop. So it is still, a risk, but it's a very exciting potential strategy, and certainly one that we've been doing a lot of, and there's been a lot of recent publications about it. So it's an exciting time as a surgeon and to get these therapies for our patients, and I think that there are lots of exciting things going on.
Next. Yes. So I think you've already heard a little bit about TIL, probably during your hope versus hype discussion. So that's all I do, is I work with TIL day in, day out. And so first off, what are they? Why do we call them TIL? So very simply, a T cell is a lymphocyte. If it infiltrates a tumor, it then becomes a tumor-infiltrating lymphocyte, so we call that a TIL. So why did we get interested in TIL in the first place? And by we, I mean my mentor and my current boss, Dr. Rosenberg, who started this work while I was still in elementary school. But the first thing that was tried was IL-2, and they found that by exciting all the lymphocytes in the body, you could get a very small number of patients that would be cured. 4% would be alive 10, 15, 20, 30 years later. Obviously, 4% is not a bar that anybody wants to settle on. And so the question was, if we're exciting all the T cells in the body, how can we find the right T cells maybe and give those back first? And so Dr. Rosenberg is a surgeon, I'm a surgeon, so we have access to tissue. So the first thing we started doing was taking out tumors of patients that had advanced melanoma. So this was melanoma that had already gotten past the primary, past the lymph nodes, had gotten into the liver, had gotten into the lung, had gotten into other spaces in the body. And when we looked at those, we could grow the lymphocytes out of them. You can literally watch them under a microscope. The T cells will crawl out, given enough IL-2, and you can watch them crawling out of the tumor over the course of about 2 weeks. When we tested those, we could find some that when we put them back up against a tumor, they would kill it. And so we decided, let's try giving that. And when we gave that to patients, we would give them on the order of billions of cells back. We would see some shrinking, but then things would grow back. So they were working, but they weren't lasting long enough. So the next step over the course of many years was to treat patients with a little bit of chemotherapy first, because what that did is it made the body hungry for lymphocytes. So when we gave back what we thought were the tumor-fighting lymphocytes, all those nutrients and things that the body needs to proliferate, proliferated our lymphocytes instead of the regular ones. And we started to really see an impact. As of today, we've treated about 220 patients with metastatic melanoma using this strategy, and we have a complete response rate, a durable, greater than 10-year cure response rate of about 25%. So 25 is better than 4, but it's not perfect. So what happened in the middle of all of this? Well, you guys all know what happened in the middle of all of this. Dr. Allison made some really important strides. Checkpoint blockade became a much simpler way to activate all those lymphocytes in the body. And so we learned a lot by using TIL in melanoma. We actually used it not only as a treatment tool for patients who have metastatic melanoma, but as a learning tool for what a T cell can do. And we've actually been able to apply those principles now not only to patients with melanoma, which is very important, but to other patients with other types of cancers like colon cancer and breast cancer. So it's been a real important learning tool for us. We're in the middle of retooling now because the questions that we were asking have changed because our patients have changed. Everyone has received pembrolizumab. I think it's in the water now. That changes those lymphocytes that live in the tumor. And so before, when we would look at a tumor, we knew that about 1 out of every 100 lymphocytes that we found in that tumor knew how to fight the tumor, as opposed to about 1 in every 100,000 in the blood. Since the onset of patients whose disease has already gone through checkpoint blockade, that number's dropped. And so we've got to learn how to get better at TIL again. It's almost like we're starting over. But it's not, a lot of people said, if a patient doesn't respond to checkpoint therapy, dumping tons of TIL into them is never going to work. They've already shown that their immune system can't kill their cancer. Well, that's not true. We have treated about 40 patients since then, and I know you guys have probably heard about some of the corporate strategies that have been happening. The response rate's not 0. It's not 50, but it's not 0. It's hovering around in the 20 to 25% range. So there's something about what we do with TIL that's different than what ipilimumab and nivolumab and durvalumab and all the mAbs do. It's a different mechanism, and so we're working now to learn that. But what we do know is that if the first line of drugs do not work, TIL still can. And so we're trying to sort out for whom it might be able to work and for whom it won't. Because it's complicated, it's not an easy treatment to go through, it's not an easy treatment to prepare. And so what we're working on now is trying to find the right patients to treat with it.
All right. So I'm a biomedical engineer who's working on immuno-oncology space at Michigan, University of Michigan. So my lab develops a new drug therapeutics that can synergize with immune checkpoint blockers so that more patients can respond to these immune checkpoint blockades. As you heard from previous talk, about 25% of patients are responding to immune checkpoint, and it'd be really fantastic to bring the number up to 70% or even higher. And one of the main challenges with immune checkpoint is that the patients who respond have a lot of anti-tumor lymphocytes within tumor tissues. But those who don't respond don't have as much T cells to begin with, so that the immune checkpoint blockers do not work as well. The way we are approaching this problem is how to increase these T cells to begin with, so that when patients are given immune checkpoint, they would respond better to the therapies. And one approach we are taking is through cancer vaccination. It's unlike a traditional flu vaccine where you try to vaccinate human patients against a potential infection, but it's for a therapeutic vaccine. And our idea is that if you train enough number of T cells against the tumor cells to begin with, they would be circulating with the blood circulation, and they would infiltrate into the tumor. And when patients are given immune checkpoint, that they would have a good handle on the tumor proteins that are within the tumor tissues. So we use the different drug delivery approaches to generate strong T cell vaccine. One promising candidate we came up with in the lab is based on good cholesterol, high density lipoprotein that's engineered to deliver a fragment of a tumor antigen. And as for the antigen, you could use shared antigens that are upregulated within tumor tissues, or there are new exciting research showing that if you take tumors out from patients and then do DNA RNA sequencing, you can find the mutations that are unique to the patient's tumor type. So we put these so-called neoantigens into our good cholesterol to have a precision approach for cancer immunotherapy. So we have done a lot of mouse studies using melanoma, brain cancer, colon cancer models, and we have seen some fantastic results. So we spun out a small company called Evoke, where I serve as a CSO. That's my disclosure as well. So we've been working with medium-sized pharma as well as large pharma to take this to the clinic. We've been getting a lot of support from local and state government to bootstrap our companies together to push this toward our clinical trials. Another approach that's really crucial after getting a large number of T cells is how to recruit them within tumor tissues, because a lot of tumors exclude the T cell infiltration. So we, as well as others, and Dr. Rivas is the pioneer in this field, use different approaches to recruit them to tumor. We use something called the STING agonist, a new formulation that we are using to activate immune cells within tumor tissues so that tumor tissues will recruit chemokines and that will recruit T cells to tumor tissues. And that has been showing some really exciting data in mouse and human trials, in all the human trials as well. And another approach that's really exciting is the role of gut microbiome and their impact on T cells. Very recent studies published in high-profile journals show that patients who respond to immune checkpoint have a very diverse commensal gut microbiome. And people are now trying to understand what's the role of these commensal microbes and their metabolites and what their roles are on T cell immunity that synergizes with the immune checkpoint. And we are coming up with new approaches to modulate gut microbiome so that you can have a better T cells to begin with. And we'll be happy to share the data a bit more later. Yeah, that's a work in progress. Yeah.
So I'll pick up on the themes that Dr. Moon was discussing. I was asked to talk about intralesional therapies, or injecting something into a cancer, a melanoma lesion in one place and having it work in other parts of the body. When we first started talking about these, most companies that develop drugs for treatment of melanoma said, oh, that will never work. You always need to give it. If the melanoma is spread through the body, you always need to give something intravenously because it needs to work all over. And that's probably true. But as you've heard from the panel, there's one system that we have that works all over the body, which is the immune system. And if we train it to recognize and attack melanoma, it's going to be able to do it anywhere in the body, because that's what the immune system evolved to do, to find something that's wrong and attack it. And if it appears somewhere else in the body, attack it somewhere else. And if it appears 20 years later, attack it again. We're vaccinated when we're kids. And an 80-year-old who was vaccinated was 15 months old. The immune system still remembers the vaccine. So can we use the melanoma to turn it into a vaccine? And the idea is to inject something into the melanoma so the immune system thinks that's something really wrong. And what happens is that in many patients with melanoma, unfortunately, the immune system is not doing anything about the melanoma. And we try to take its brakes out, as we discussed, and the immune system still does not target the melanoma. It's like if we wanted to make a fire and we have a pile of wood and nobody has put the first match. Well, this intralesional therapy is to lighting the first match. You light up a little place, and then the fire spreads throughout. So we want to light a fire under the immune system, and we do that by injecting into the tumor sequences that look like bacteria and viruses, or even we can inject bacteria or viruses. The first therapies like these were tuberculosis bacteria that were injected 100 years ago, or even if we look at Middle-aged books, there were some people that would inject some bacteria into cancer lesions and be able to stimulate an immune response occasionally. So now we have a more refined methods, and we know exactly which sequences of bacteria and viruses are recognized by our immune system that can jumpstart the immune response. And those can be made synthetically and put into a vial and then inject it into a lesion, and that would turn on the immune system throughout. The other approach is using recombinant viruses that have been genetically altered so they could preferentially infect cancer cells and then inject that with the same idea. And all of these will work best if we then unleash the immune system by giving an anti-PD-1 or anti-CTLA-4, an immune checkpoint blockade therapy that would allow that local immune system to work anywhere in the body.
Okay, so we heard a little bit about all different types of approaches, most of which are currently in clinical trial being investigated to, again, try to raise the bar from where we saw it currently is to much higher. So we wanted to kind of keep this open, so we'll now open the floor to questions. Just let us know kind of who you're specifically asking the question to, because we did hear kind of a variety of different talks.
Or we'll figure it out.
Yes, or figure it out.
My name is Dave. I'm from Arlington, and I'm a patient. My question is about earlier someone mentioned that the U.S. has a very low participation in clinical trials. As a group, why do you think that is the case?
Ken?
I can tackle that. I think we're in some ways suffering from our success. So back in the early days of melanoma, when I started my practice some 10 years ago, without other options, we had excellent accrual rates. And that's come down to some degree because now the frontline options are so good. The PD-1 inhibitors are working well, and most patients are trying those in the very beginning. The rescue strategies that are available are a little less clear in terms of their benefits. So the trial options available to a patient in the US are not so superior to what's available standard of care that the patients are flocking to participate. Other countries have a more restricted healthcare system that tends to channel patients better into those trials, and their participation rates tend to be a little higher. And I think us as a one hat that I wear is for this group called the Southwest Oncology Group. And part of our efforts within that group are to, first of all, design exciting trials that patients really want to participate in. And then secondly, build networks with our community oncology colleagues where the trials may not be as accessible. It's very hard, for example, a small community clinic or hospital to have the infrastructure needed to put a patient on a trial. And so, again, historically for melanoma, patients would have to travel a long way. And in my case, in Utah, I would have patients drive 10 hours from Montana to come participate in a trial with me. And obviously, when you think of a every 3 week, every month visit, that can really add up over time. So building our collaborations out to those satellite sites, trying to get them participating in our research and making sure the trial comes to the patient rather than the other way around, I think are some things that we need to work on in the US.
And I would say, and I don't see pediatrics. I don't know if there's anybody up here who sees
do,
kids.
yeah.
Yeah, but I should say U.S. adults. I believe the U.S. pediatric clinical trial enrollment is absolutely excellent, and that's because of a network. Anytime a kid is diagnosed with cancer of any kind, they are enrolled on a clinical trial. It may not be the next intervention trial that's going to determine, the next first-line therapy. May be asking a simple question about what drug's better, to give first or second or whatever. But so the U.S. can do it. It just needs, the adult oncologists, and the rest of the team. I think just need, again, some a little more collaboration and networking and all the reasons you said. Yes.
Online. I don't have a name, but this person wants to know if palliative care is something that you can do while participating in a clinical trial.
So palliative care, defined really just as, help with any type of symptoms, whether it's physical symptoms, emotional symptoms, relationship issues, can really be started at any point in someone's cancer journey. So certainly someone can be on a clinical trial receiving palliative care. Different than hospice care, which is a bit of a different conversation, but certain palliative care in any form of symptom kind of support can be done while patients are on clinical trial, as long as there's not an intervention. So we talked earlier, the session before us, about vitamins. So there are a number of clinical trials that actually will exclude patients who are currently on any type of herbal supplement. So you just have to be careful that part of the palliative care isn't using certain herbal supplements, because that may be excluded on the clinical trial.
I'm Robin from Portland, volunteer with OHSU with melanoma advocacy and research advocacy. I know that our primary care banks are going live now, are put in. How will the availability of primary tumors change your research or improve your research?
Yeah, because that's actually really important, because I do a lot of, and trying to figure out this who needs adjuvant therapy question that I mentioned. One great place to look is the primary tumor, and it's actually pretty difficult because many of my patients come from outside dermatologists, and getting the blocks and things that we need to do the tests that we want is a real challenge. And primary melanoma, unlike a lot of other tumors, there's usually not very much of it. Usually a lot of it's used up by the diagnostics that we need to perform. So it's not like some of these larger tumors where there's plenty. So resources like that could be really valuable for especially the earlier stages when we need to look in the primary tumors.
My name is Mary Lou. I'm actually going to speak to you, doctor, as well, because that was pretty much the line that I wanted to ask. My son was diagnosed with stage 1A, and so they did the incision, looked for clean borders, and they put him on the protocol, come see me every 3 months. But while he was being seen every 3 months for 2 years, as the protocol, I've been told, calls, the cancer had started to go into his system, and when it was finally discovered, when he finally had symptoms, he was stage 4 and had 100 days to live. So would adjuvant therapy be used for a patient with stage 1 or in situ? I mean, melanoma is not melanoma, and it only takes one cell to go into your system, so.
Well, I'll let the other surgeon maybe potentially too, because I know she sees, but I think if we can figure out who are the patients at really high risk, which may include some stage 1 patients. Certainly I think we know there's a lot of stage 2 patients that I see. That means when we do the sentinel lymph node biopsy, we don't see tumor there, but we know based on their primary characteristics, they're extremely high risk of recurrence. And there's been a few trials that have looked at treating those patients that were unfortunately negative, but we certainly know there are some patients that are very high risk, whether or not their sentinel node was involved or not. And I think if we can figure out who those patients are, then sure, they could probably get adjuvant therapy.
I mean, it's not exactly in my wheelhouse, but the types of banks that you're talking about where you're able to go back and correlate outcome with genetic changes in the primary. Maybe someday we'll be able to create a profile that says, yes, this was very thin, yes, this wasn't ulcerated, no, this didn't go to the sentinel node, but it's got these genetic changes that we know in 12 of these patients that had it, they had poorer outcomes. So maybe we need to look a little bit more closely at that. We're not there yet, but that's what these banks would help us eventually get to.
Hi, I'm Trip. I'm the brother-in-law of a patient right here. Hi. Thank you all for being here. Dr. Ribas, this is for you. So are there limitations to the type of therapy that you're working on based on the site of the tumor? So for instance, a lung tumor, can it be injected?
Yes, there are. So the therapy is based on injecting not just once, but multiple times. So you're absolutely right that depending on the location, it's going to be easier or harder to inject multiple times. It's a therapy that's being developed first where it's easier to inject in cutaneous, subcutaneous, lymph node lesions that can be palpated somewhere in the body. There's studies where they're injecting in metastasis in the liver because it turns out that there's always a risk on any injection, but the radiologists that do injections are pretty good at getting to these lesions specifically. To go repeatedly in the lung would be a stretch of this therapy at this time. I think we would need to have more evidence of the benefit, or at least the magnitude of the benefit. We know there can be benefit because we've seen patients who were progressing on prior therapy who respond on intralesional therapy plus continuing on anti-PD-1, but it's a subset of the patients. If we increase the risk while doing the therapy, then the risk-benefit may go down. And it's in the lung, repeated injections, unless it was a very peripheral lesions, can have complications in getting air into the lung, which is called pneumothorax. So that would not be the place where we would be planning this therapy right now. The good thing about this is that we're not talking about just one therapy. And there's a series of therapies that have come at the same time that you've heard throughout the day. And now we're talking about what's next, what are the next steps. Well, the next steps are guided by what worked and how do we understand what worked, and what didn't work and how do we think we can intervene to change that. And this would be one of the ways. You've heard several others.
So just to piggyback on that question, if you have more than one metastatic lesion, do you need to inject many lesions, or can you just inject one lesion and see responses in other sites?
We know that we can inject some lesions and have responses in the injected lesion and non-injected lesions, especially if it's given the injectable therapy with checkpoint blockade therapy that allows the immune system to amplify and go to other places. Some of the clinical trials were based on injecting just one lesion, but many others are allowing to inject several peripheral lesions, and then there's usually some that are not injected. So it's not a requirement. We don't know if it's better to inject more or less. That's something that we'll need to figure out.
Yes, this question is for Dr. Moon, I believe. Does vaccines, therapeutic vaccines, have a role for patients who were stage 3, had surgery, and following lymph node involvement have no evidence of disease? Is that the scenario where the vaccine would be utilized, or in different scenarios?
Yes, I think after surgery, the vaccines could be used to prevent a future relapse. So in the neoantigen, the personalized immunotherapy trial that I mentioned, that was done in that setting. So they took the biopsy out after surgery and did the DNA, RNA sequencing to find mutations, and then they designed personalized the vaccine and given in combination with immune checkpoint, and saw a real prevention of tumor relapse. So in theory, that can be the future direction. Yeah, and the studies are ongoing. Yeah.
I have a question for someone online, specific to Dr. Goff or others. This is in regards to a 30-year-old patient in California. And they are curious about treatments or trials for people with both BRAF and PTEN mutations.
I'm not sure why it's directed at me. I actually think Dr. Grossman
We're all
handled that one a little bit better.
It's a terrific question, and in many ways, he's stumped the chumps. In some senses, we would really love to know how to overcome the drug resistance caused by PTEN loss. It's a very important thing that's been raised, and the group here are keenly interested in researching it. We do have a variety of ongoing trials that are looking at combinations of BRAF, MEK, and AKT in the case, and Tony may be able to speak more to that. But we've yet to identify something that is really exactly the right combo to go after that particular change. And I'm not aware of any studies that, at least I have at my own institution, that are seeking just BRAF PTEN. Tony, do you want to add anything to that?
Yeah, so that's a combination, unfortunately, where our current therapies are not performing that well. A young patient with a BRAF mutation, which is BRAF mutations are more common in younger people, in melanomas that develop in younger people than in older age. And then this PTEN, which is would be two pathways that are both feeding to the cancer growth. So the BRAF is turned on. It's like having a switch that's always on and telling the cancer cell you have to grow all the time. We know we can block that, but then is there another pathway that's saying the same, and the PTEN loss is doing the same? And that leads to lower responses to patients who are receiving BRAF and MEK inhibitors, but also there's data that this PTEN loss also leads to less responses to the immunotherapies for reasons that are still not clear. That doesn't mean that therapies don't work in this situation. They do work, and we've seen responses in both cases, just that it's a lower frequency. So that's why it's so important for us to continue to study these cases, study the patients who respond or not, understand mechanisms, work in the lab to model them, and then come back with new therapies. I think that's what we're all here, because the Melanoma Research Alliance is very active at looking at what works and wasn't, and then funding research that addresses these limitations. I think a case like this, unfortunately, would be one of our current limitations that we need to study more.
Just a couple of questions that aren't really related, I don't think, but I'm just wondering, how far are we from having CTC tests and proteomic analysis sort of more commonly or at all used in clinic, and how would that change what you're doing, if at all? I don't know if any of that makes sense, because I feel like I keep asking doctors this and they look at me like I'm nuts, and so I'm a little confused about CTC testing and proteomic analysis, if that's ever going to be available, if it already is and I just don't have access to it, or what. But my second question is, could these type of injections be used to replace the original wide excision surgery? Or could a neoadjuvant treatment, some other neoadjuvant treatment be used, I guess this is for Dr. Beasley, be used to replace surgery to make it not necessary to begin with?
If I could tackle number one, and then I'll hand off number two. So for number one, we've been desperate to find a circulating marker that can tell us whether or not the patient has what we call minimal residual disease, meaning that before or after surgery, if there were circulating tumor cells or circulating tumor DNA, those two things would tell us whether or not that patient was high risk of relapse or actually had cancer that we couldn't see in our scans. There is some recent work published from MD Anderson with circulating tumor cells, and it does show an impact on an adverse impact on the outcome. So as you might suspect, circulating tumor cells are a high risk factor. Where I think the field is headed is more circulating tumor DNA because of its sensitivity. So if we can amplify fragments of DNA that are present in parts per million, really, they're just so rare, but with the high sensitivity technology that we have through companies like Natera and TGen, those two companies are developing things that I think are getting really close to being capable of detecting minimal residual disease and perhaps predicting outcome. So I would forecast within the next maybe even 2 to 5 years, we've got something that we are able to monitor our patients' blood with, perhaps someday replacing scans for surveillance. So I think the questions you ask are really forecasting our future, and I think it's bright. Question 2.
It's a very interesting question that you kind of stumbled on. So I, as a surgeon, of course, I would love to put myself out of business as a surgical oncologist, and I say that honestly. It would be wonderful. You know, the problem is if I knew that a patient, when I removed, was going to have this, what we would call a pathologic complete response. So we've been seeing a whole gamut of when I take the pathologists say this is complete, there's a range from complete fibrosis, meaning they don't even see that the melanoma is even there. Then they see sometimes melanophages, which are sort of dead melanoma, and then sometimes, of course, there's still tumor, right? So there's this whole, so if I knew with 100% certainty that this patient the tumor was going to be completely dead and there was going to be no evidence of it, yes, but there's no way of knowing that right now. And we don't know who those patients are. You know, in the metastatic setting, you know, you've heard all day the response is about 40%, so we would expect about the same. So if I assume that person is the responder, then, you know, I'm missing a large, you know, I'm just guessing. A lot of people are looking at, can we figure that out? Because if we did know, in fact, that this patient was not going to have any tumor and that it's all dead, then yes, maybe, but figuring that out is a real challenge. If you just take a little biopsy of it and say, yeah, this is dead, well, you didn't look at the whole thing, you know, the whole tumor, and so it's a real challenge. And as of right now, certainly one that I'm not really to take a chance. You know, on the CT scans as well, we noticed that the tumors don't necessarily, the size doesn't necessarily shrink. So unlike other tumor, you know, rectal cancer and stuff when I did surgical oncology training, the tumor on the scan, you can make some guesses that the tumor got smaller. But we've seen whether it's because immunotherapy is a little bit different than chemotherapy, the size itself may not change, but it could still all be dead. So we're really not in a place yet where we can guess who those patients are, and so I'm still in business for now, but happy to be out of business.
I have a question from an online viewer for Dr. Beasley again. With regard to adjuvant therapy, am I understanding that a patient with metastasis can undergo surgery of the primary site as an initial treatment so that there are less cells for future treatment, less cells that the future treatment has to fight off?
So I'm not sure, maybe I didn't explain it right. So what I'm talking about, an adjuvant therapy is when we've removed, you know, so the primary, usually, you know, the primary treatment is wide local excision and sentinel node, let's say. And then if the sentinel node is positive, and I'm sure most of the institutions are the same, then we do like a PET scan or something to make sure there's no other known spread that we can see or feel, so no other overt metastasis. So he was talking earlier about if we have another test, circulating DNA or some of these things, but right now we don't have it. So for that patient, the best we know, they don't have any known disease, but we know, because we followed these patients, that they're at high risk for recurrence, so we presume there are some cancer cells still floating around in some of those patients. And so for those are the patients that we might guess that adjuvant therapy, getting some systemic treatment at that time, would reduce the chance for it to come back. So I'm not sure if I answered the question, just explained a little bit better what I'm talking about. So we don't have evidence, when you're treating someone with truly adjuvant therapy in the strict definition, those patients have no disease that we can see or feel at the time, although we are worried and can guess that there might still be some cells floating around.
And if I could add maybe just one thought to what you shared. If we had the perfect test for deciding adjuvant therapy, in my mind, that's a test that says this patient will never relapse. If we had a blood test or a primary tumor test that could say this patient never will relapse, and we could be 100% confident in that. We could spare them additional surgeries, additional immunotherapy, and all that. And one of the things that we've been working on are better definitions for our community of what are the operating characteristics of such a test. How good does it have to be? How perfect? Does it have to be 95% predictive, 100%? Like what do we as a group feel like is a sufficient power for that test? And I would like perfect, but I would take something pretty close to that, and I think we're getting there.
And I'd kind of add one thing on, and perhaps this is what the person asking the question was asking. So there are sometimes someone's had their primary treated, they may or may not have a sentinel node, and then they develop one metastatic site. So maybe just a lung lesion, or just, one site. Sometimes we do something called a metastectomy, where they may get surgery to remove a metastatic lesion, and then declare them kind of no evidence of disease after that. Sometimes we do then give adjuvant. It's not true adjuvant, as Dr. Beasley explained, in that you've already maximally managed their primary tumor, but now you've made them no evidence of disease. And in that case, yes, you may give systemic therapy after you've done surgery to remove, one or sometimes even two metastatic lesions, again, kind of making that potential mountain more of a hill.
I have a question from Evan from Ohio, and he's curious of which of the approaches that have been outlined would be an option or maybe an option for folks who do not have cutaneous melanoma, so something that would work for one of the rare subtypes that Dr. Orloff mentioned.
So I can take that one. So it depends on which rare subtype, and sometimes it depends on which subtype of a rare subtype. I didn't take that much time to kind of go through all the intricacies, but so say for instance uveal melanoma. Uveal melanoma, I don't know if there's anyone in the audience with ocular melanoma or here's an advocate for ocular melanoma, but it is a very different disease. What I sometimes tell patients is, other than the fact that they kind of look the same under the microscope, sometimes that's where the similarities with cutaneous melanoma end. Just because the journeys can be much different. So in uveal melanoma, the most common place that it recurs is in the liver. It very rarely shows up, actually it doesn't really show up in the lymph nodes. So sentinel lymph nodes, as Dr. Beasley mentioned, aren't really a thing. So, to talk about neoadjuvant or adjuvant therapy for uveal melanoma, it doesn't really apply when it comes to looking at sentinel lymph nodes and things like that. The primary tumor starts in the eye, and you don't necessarily want to give a lot of lag time in leaving it in the eye, mostly because the area is much smaller, right? So if you have a lesion on the arm or you're talking about a lymph node, that can get pretty large before you can get into real trouble. When you talk about the eye, you're talking about a very small location. So in those cases, patients who show up with a very small tumor in the eye will often get it treated right out of the gate. And then in those cases, like I said, the majority of patients will recur in the liver. And oftentimes in those patients, liver disease, liver failure becomes the life-limiting situation. So, and they also don't have BRAF mutations. So when we talk about targeted therapy and triplet therapy, which combines immunotherapy and targeted therapy, that's not really a thing for uveal melanoma. In those cases, the mutations that I threw up there, the GNAQ, GNA11, and there's another one called BAP1 and SF3B1, aren't really targeted with BRAF drugs. So, triplet therapy, as we talked about, wouldn't really apply. TIL therapy can be an option, and there's a number of programs in the country that are looking at TIL therapy for uveal melanoma. While it's a similar process, the response rates have been different, and I think the hurdles that we're seeing with TIL and uveal have to do with how reactive those T cells are and how recognizable the tumor is to the T cell. So some of the issues with immunotherapy are that you can boost the immune system all you want, but if for some reason the tumor is really good at hiding and is not foreign enough, it doesn't really matter what the army looks like. And in uveal melanoma, sometimes that's what we think, is that it doesn't have as many mutations as skin melanoma. It likes to hide out in the liver, which is a great sanctuary. So there's different hurdles that we're seeing with TIL therapy. Vaccine therapy potentially could be an option. And intralesional therapy, in some cases, can be an option. There have been some studies, when you talk about injecting the liver, again, in uveal melanoma, that's the primary site. Mucosal melanoma, I think a lot of the options, certainly actually I think adjuvant and neoadjuvant therapy in mucosal melanoma is probably a really important area to explore because those patients will often present with really bulky disease that may not be resectable or maybe borderline resectable, and maybe you'd want to shrink it a little bit. We're talking about if lesions are in the nasal cavity or vaginal melanomas or rectal melanoma. So again, I think it's very important to know which rare subtype you're dealing with because to pick and choose from all of the options on the stage may differ. So my question to kind of the group was going to be, if a patient fails the standard of care, how do you decide, which treatment to go to next? And again, I think number one is, to try to figure out what your subtype is. But do you have an algorithm for kind of what you go to next, or is it just what clinical trials are available at your institution, or are there features of the patient's tumor that you look at to really kind of figure out what the right next move is?
I would like to make one thing. I think we fail the patients. Patients don't fail treatments. So I cope with, and it's on us to need to know more and develop better treatments. And that's what we're all committed to do here. There's the therapies that we've developed that were in clinical trials some years ago are now standard of care, and they're being used widely, and that's a great success from the treatment of melanoma. If we look at the history of cancer treatment, melanoma may be one of the cancers that has had the most changes, favorable changes in the shortest period of time. The last 10 years have dramatically changed how we treat this disease. Still, our treatments don't cover everyone, and we have to do better. We do personalize the discussion depending on what was the frontline therapy, was immunotherapy or targeted therapy, what are the options that we have in clinical trials, what are the options that we have referring to other places for clinical trials. We've referred patients to the National Cancer Institute to get TIL therapy. We've referred patients each other to discuss patients with alkyl melanoma and others in more specialized centers that may have more clinical trial options than others. We encourage patients to talk to each other, go online, and look for options. Some of them are misguided, but some of them are not. Sometimes patients come back and say, look, I heard about this thing. What do you think about it? And if they're right, we should say it. So, well, that opens up an option, and we always want patient participation in their care.
Yeah, and I think that summarizes something that we actually are unclear as to the best rescue strategy beyond our standard of care options. From my point of view, there isn't yet a perfect thing that you can do in a community setting, which is why the trials are so important. So.
Hi, my name's Lynn. I'm from DC. I have a general question for the group and then a more specific one for Dr. Goff. Generally, what does the process of transitioning from a clinical trial to an FDA approval process look like? You all are doing a lot of different things, but I'm just kind of wondering if generally you can give us a sense of what that looks like. And then more specifically with TIL being sort of in that process or about to be going through that process, if you could kind of speak to that a little bit more specifically.
The quickest answer to the first one is that it's a long and varied road for lots of different reasons. I think that many of the people up here had experience with, I think ipilimumab was first given to a person in early 2001, and we were looking at approval in 2012. So you think about sort of what that took. The development of ipilimumab is actually a really interesting story because we had to think differently about how to develop drugs. You know, when you give a chemotherapy or you give a small molecule inhibitor, you push toward a dose-limiting toxicity. And so when we were giving ipilimumab, we started seeing toxicities. And so the first thing the FDA said was, whoa, stop, right? But then what we discovered was the same patients that were having those toxicities were having the responses. And so for one of the first times, response and toxicity were linked. And it's not necessarily because it's a toxicity, it's because we learned that by activating all the T cells in the body by taking those breaks off. You were activating ones that knew how to see normal tissues. And so the FDA had to change its paradigm a little bit and say, okay, you're hitting dose-limiting toxicities, but patients are doing better. We're going to let you push those dose-limiting toxicities a little bit more and actually let us increase the dose, right? Went from 0.1 to 1 to 3 to 5. And we actually did it within a patient, you know, so that we could say, well, they got a dose of 3, didn't do much. We gave them 2 doses of 5. Started to have a little bit of trouble with their thyroid, but look at what their tumor's doing. So it was a completely new paradigm for the FDA. And it just goes to show the importance of vigilance in phase 1 trials, because you never know what's going to happen, right? And if anybody else wants to speak to that more specifically before I get into TIL, because that's a whole different ballgame. But TIL, as you might imagine, it's not a pill. It's not a monoclonal antibody. It's not something that you've got stuck on a shelf. It's actually getting approval for an entire process. And so we were actually making inroads on that before the checkpoint revolution came about, right? So what we now need to demonstrate is that it's still feasible. It still can be done. It does require specialized work. So in our center, you know, we've been doing this for a while, so we can grow TIL from 97% of every tumor that we take out. We very rarely have growth failures. Now, we don't always have recognition. We don't always see patient responses, but we can grow them. And so as this has moved into ways to make it a little bit easier, you know, we take a tumor, we chop it into 24 pieces, and we grow each one of those 24 pieces individually. That's not feasible for every lab to do. That's not feasible even to send a piece of tumor off to a central site to do. So people are looking at ways of just taking that tumor, digesting it, and throwing it in a flask and leaving it there. And so that growth rate isn't as high, but it's a standardized process. It can meet all the requirements of GMP, which I just recently jumped into that world, and I want to jump back out. It's horrible. What we used to do in the lab with about 6 people, we now have about 10 people doing, and we have about 20 people watching us. So it has become complex. And so cell biologics, I think the CAR T products that are out there now, which I am in no way saying that I think CAR T is where we should be going for melanoma, but getting those approved, that's the process that a cell product needs to go through. And it took the companies that did that probably on the order of let's see, the first CAR T for lymphoma went in 2009 and just got approval 2018. So that still took about 9 years.
Jackie. So, quick question. Back in 2007, I was on the PEG-Intron trial, and then I had a groin dissection. I was on the PEG-Intron trial, and then also had radiation. So, wondering, was anyone else ever treated with PEG-Intron? Because in all these years, I've never met another single soul. No one knows what I'm talking about. And 2, with the rise of neoadjuvant therapies now, are we cutting back on radiation, and or would someone who's stage 3 be treated with a neoadjuvant and then not have to go through that in the end?
I'll tackle maybe some of that. PEG-Intron was a terrific idea in the sense that it was going to prolong the half-life of interferon and hopefully overcome some of the toxicities that we had with that drug. In actual fact, interferon was probably the first drug ever to immunotherapeutic to show an advantage in melanoma. So we got to PEG, and a lot of patients have done well with the PEG interferon. Where it's gone now is our therapies are so much safer, and they're better tolerated. So we're using less of the interferons, but they may make a comeback because the mechanism of those drugs is very important to activate T cells. And in the more advanced patient, we may actually see some of those drugs make their way back into our clinical tools. Anyone else have a response?
Yes, a little bit on your second part about how you might have been treated differently. I think it's really important when we're talking about this neoadjuvant that it is still in a clinical trial sort of setting only and still sort of, experimental. And so we don't go around, advocating it for everybody and, to be done in the community, because it really does require very coordinated effort and sort of a dedicated, both medical oncologist and surgeon and sort of a whole team. But certainly if I'm not, the details of your specific case, certainly if you showed up with sort of palpable large lymph nodes in your groin, we would consider, if you were, seeing us, you would consider the approach, but we'd have to, again, walk you through all the benefits and risks. So it's a little hard to say, if we would have treated differently, but certainly, yes, in this day and age, we might consider somebody, presenting that way for that type of approach.
And I just want to go back to, I think, the question before that. Were you asking about what happens if someone's on a clinical trial and the drug that they're getting then gets FDA approved? How do they then get it? Not necessarily. Okay. All right. Yeah, I was just rethinking kind of the way you asked the question. So I mean, there's been patients who say were on those original kind of ipilimumab trials, really any of the drug trials, the drugs have been approved. And there is a period of time where there's something called like an expanded access program, or there's different names where the patient will go from kind of getting the drug on trial to then kind of getting the drug as standard of care through the insurance. And it has to do with kind of how quickly the hospital or institution that they're getting the drug kind of figures out how to get the drug as part of standard of care. But there's not really a period of time where the person would like not get the drug. There's, we don't put patients in that kind of limbo.
I was asked to ask a follow-up about the radiation question that was asked. Could you elaborate a little bit more about what the current role of radiation therapy, and do you see that continuing or increasing with some of these other approaches, or just kind of help us understand how it fits into like checkpoint and targeted therapies?
I think, I don't think I'm the perfect person to be answering this question, but there are some interesting data coming out, not necessarily in melanoma, but in other cancers, in gastric, in pancreas, in breast, where the use of targeted radiation is not meant as curative. Radiation is almost always used as local control, but in a sense as a sort of vaccination, with the thought that if you kill the cells within that lesion that you're irradiating, then that's doing much the same thing as some of the vaccines that you would inject, right? It's releasing, theoretically, this is all a hypothesis, releasing those antigens, creating new space for the T cell to see that tumor as foreign. Because that's the trick, really, is once you trick your body into thinking that the cancer is foreign, that's when all these other opportunities explode. And that's whether your body does it on its own. There are spontaneous regressions. They're rare, but they happen. Or whether checkpoint inhibitors do it. But once you've, like Tony said, lit that fire, some people believe that there is an effect where if you irradiate a tumor, that can be that first match stroke. But as far as control for stage 3, I don't do primary melanoma surgery anymore. I solely do metastectomy, so I would leave that.
Yeah, I think much like a surgeon, radiation and sort of the earlier stages really only is controlling disease in that site. And that's really important because the patients, as we spoke about, are the ones really at risk for this spread, and really their whole body needs treated. And I'm talking about the earlier stages when I say that. So I think there's still a little bit of a role, but I think it is becoming less because we have better treatments now, and that's just the reality. So as we have better treatments, radiation as a therapy that's really a local therapy, especially and at the early stages, is not having an impact on the whole body as a surgery. And so I think we're moving, especially in the primary and earlier stages, we're moving a little bit away from it, but certainly there's still a role in some patients.
I guess the one other thing to add is that the use of radiation for patients with brain metastases is probably the single most important thing that we see it used for, and it is highly effective there. The tumors that they are able to see and treat are almost always controlled and rarely progress. Obviously, we are only treating what we can see, so there's other sites that will perhaps grow, but the effectiveness of it, being able to cone down on one little spot and treat it effectively is really remarkable. And in fact, it's probably one of the safest and easiest treatments that we're giving to our patients in melanoma right now.
I have an online question from Ken. He is asking about BRAF wild type and what sort of approaches might be something that he has to possibly look forward to.
So all of the approaches that we discussed, besides the BRAF and MEK inhibitors, it turns out that the BRAF and MEK inhibitors, which there's 3 of them approved, 3 combinations, they should only be used in patients with a BRAF-driven melanoma, because if there's no BRAF mutation, the drug would paradoxically potentially make that cell grow. All cells have BRAF. It's only the mutation that's sensitive to the drugs. And if the mutation is not there, the drugs may make that cancer cell grow faster. So besides that, all of the other options are options for patients with BRAF wild-type melanoma. That would include the checkpoint inhibitors, anti-CTLA-4 and PD-1, the combinations of immune checkpoint inhibitors, TIL therapy, injectable therapies, vaccines, adjuvant therapies, that they should all be available. It's just, it's not better or worse to have a BRAF mutant melanoma. It just, we need to adapt to that situation and treat it as it is.
And I know we've talked a bit about BRAF, and we had the question about BRAF and PTEN. Are there any other mutations in melanoma that are currently targetable in clinical trial, or that we should be on the lookout for, or patients should get testing for?
Well, I'll try and answer that one. I think probably one of the biggest opportunities in melanoma right now is targeting NRAS. It's a common mutation. It is, RAS family mutations are present in so many other cancers, so understanding how to target that particular molecule is of keen interest to a lot of us. It turns out downstream of NRAS is BRAF, and simply targeting there is not sufficient to tackle NRAS-driven tumors. So there are a variety of strategies there. One thing about NRAS that makes it kind of tough is it doesn't have a nice binding pocket. Like one of the things that we've been able to do with proteins like BRAF is design very specific drugs that can go fit, lock, and key and sit in that particular binding pocket. NRAS doesn't have those kinds of features that make it amenable to one specific drug to target that one specific gene. So long story short, we're still trying to figure that one out, but I think it's a very important frontier that we need to conquer.
It's Dave again. I'm still from Arlington, Virginia. Still a patient and still alive. So,
still awake?
My question is, as a stage 4 patient, I started as I guess stage 2, and then quickly learned I was really stage 4. Brain, liver, and lungs. Thanks to both combination of surgery and immunotherapy, I'm in pretty good shape 3 years later, and I'm grateful for that. I've been told that people ask me, where did this start? And I only know where we discovered it, which was probably where it ended, a little bump on the top of my head. But so my doctor has said unknown primary, and I'm wondering whether that is important or not, perhaps related to the regression that you've talked a little bit about, or whether it just is something now that doesn't matter.
Around 5 to 10% of metastatic melanomas present as metastases without having a primary. So your case is not the common presentation, but we've all seen it. People have taken the genetics of melanomas that appear, like in your case, spread through the body without having a primary lesion that's evident in the skin, in the eye, in the nose, or in the anus, and not that you would need to have studies of all of these. And by looking at the genetics of it, the great majority of melanomas that we call of unknown primary actually are melanomas of skin primary that went through the blood and made metastases, even if the skin lesion was never detected. And that's because those melanomas have an imprint of damage from ultraviolet light from sun. And that imprint is taken into the genes of the cancer. And that's probably why you responded to the immunotherapies, because those alterations allowed your immune system to detect the cancer cells as different from normal cells in your body. How could that happen? Pathologists have known for a long time that sometimes a primary melanoma has a part that seems to be eaten up by the immune system, which we call a partial regression. And you can see immune system cells there or fibrosis in part of the primary lesion. It is possible that the whole lesion may have been wiped out. But the problem was that some melanoma cells escaped through the blood and made seedings. And for whatever reason, those melanoma cells must have been a little bit different from the primary ones because they no longer were a target of the immune system until we unleash its brakes. People have looked back and see, do people that have a partially regressed primary melanoma or an undetected primary melanoma, if they do better or worse? And the data is not that clear, but if anything, it seems to be a worse prognosis slightly. And that's probably by a process that we call editing of the cancer cells, where the immune system attack led to a partial gain of a battle, but some cells escape and those cells were tougher and not as detected by the immune system, and then maybe harder to treat before we had these effective therapies. Now, I don't think we have any evidence that your presentation is better or worse than any other presentation. Complicated stuff, though.
Yes, I was going to ask, in the case of spitzoid melanoma, are any of these treatments been either researched or tested with respect to spitzoid? Any indication that any of these treatments work any better or any worse with respect to that kind of melanoma?
In general, the spitzoid melanomas do have a more favorable prognosis, but we've actually learned over the years that sometimes our recognition of them is not as good as we would like, and occasionally one that we think is going to do well behaves a lot more aggressively than we otherwise would expect. So any particular therapy directed there, I'm not aware of any that are kind of honing in on that unique subpopulation. Maybe my colleagues have some more information there.
So there's something about how we call things and where the names come from. So Spitz nevus are pigmented lesions that appear early in life, and sometimes they would grow very rapidly. Sometimes they would show metastases that they spread to the lymph nodes. And even in those situations, they were not a real melanoma. They were pigmented cells that had ability to grow to a certain stage and then stop. That's the Spitz nevus. Those cells have a certain shape, and other melanomas that are real melanomas that grow and give metastases have a shape that looks like a Spitz nevus. And then there's everything in between, the ones that look spitzoid that are Spitz nevus and the Spitz nevus that don't look as much. And that becomes a problem mostly in pediatric melanomas where we don't know if it's the benign appearance that will not go beyond initial stages or it's the really bad one. What has made the change is people who have studied the genetics of this disease. And there's an investigator who's here in the meeting, Boris Bastian, who's been looking at the gene marks of these Spitz nevus and the spitzoid lesions and everything in between, and being able to define these different stages. And that is something that we hope will be used to enhance the pathological analysis and tells us exactly what it is.
probably have time for one more question. Anything online, Cody? Okay. Okay.
It's for the whole panel. What keeps you up at night? When it comes to fighting cancer and helping push it forward, what keeps you up at night thinking about it?
Maybe I'll start with this one. This goes back to kind of my early years as a PhD student. My graduate advisor used to say that the best ideas you have are when you're in the shower. It is true that I kind of tend to think about science and medicine probably more there than when I'm falling asleep. My mind's a little fresher, and I kind of see things a little brighter when I'm in that place. And where I think the field is going is getting better tools to detect the high-risk patient. I think that's really important. Our circulating blood markers, things that we've been talking about in this session, really key to identifying that person who's at high risk at the time of surgery. And then sort of the combination strategies that we touched on earlier. How do we get beyond triplets? Are there quadruplets? Are there more combinations that we need to be thinking about to hit all the possible targets? I'll maybe hand that over.
So this is, personal or whatever, but what keeps me up is, did I hurt somebody? And not necessarily that a bad, a error or technical error in the operating room. That's pretty uncommon, honestly, but are they going to get complications? And by removing the tumor, have I really helped them, or did I potentially hurt them? So if they have a complication or something, then they can't get the therapy they need, or anywhere along the spectrum. But because I get to help a lot of people, and that's great, especially at the early stages. I have clinic next to the medical oncologist, and she gets to hear me say, is your sentinel nodes negative? And she says, I never get to tell anybody that. So I get to tell a lot of people that some good news, really. But what keeps me up at night is for sure, did I hurt somebody? And that's something that I can only do our best, but that's always on my mind.
The patients that I have the opportunity to get to know are all sort of near the end of their journey. They don't make it to the NCI really until they're looking for that last vestige of hope. And really it goes along the same lines, did I hurt somebody? And really the science is all there, the clinical support is all there, and the question is, the most valuable thing this person in front of me has right now is their time. And am I making the right decision by asking them to come spend 3 weeks with me in Bethesda? Do we have the tools to make that a worthwhile choice for them right now? Or should we have a more honest and upfront conversation about the fact that 3 times out of 4, this isn't going to work? And if you've got a wedding or a graduation or a trip to the beach, is that the right option for you? It's not often that people seeking clinical trials, I don't want to say I turn them away, but I want to help them make the right choice for them. Because I think what we need to recognize is time is what they have, and that's a currency that I don't want them to spend foolishly.
For me, as a basic researcher, we want to publish results that are well validated so that other groups don't chase wrong leads. So we pretty much make sure that everyone does the best science that they can do, and we try to validate all the results before sending out for publication. That's a way of disseminating our research. Because we are given the trust of the people, we are getting funding from federal governments through taxpayer money to advance new drug development, and we want to make sure what we are publishing are well validated before sending out. Yeah.
For me, from now on, it's going to be picturing Ken Grossman thinking about science. but besides that, sorry, we're good friends for years, so it's the last question. Actually, it's individual patients. It's individual cases where either we didn't do enough, or we didn't know enough, or that it led to a toxicity, or it led to something that was, or we're anxious to be able to put on a clinical trial, or we don't have a clinical trial slot, sometimes a clinical trial closes, and then there's a next patient or an earlier patient that didn't make it, and that really keeps me up at night. I do agree that doing good science, doing good both laboratory science and clinical science, and being able to report things that are reliable, that help others, that are never misleading, I think that's one of the things that we're willing to do, and it would keep me up at night if I was involved in anything that was not honestly advancing the field.
And just to kind of circle back from, the presentation in the beginning, that we all feel that, we've done so much and the field's come so far, but we can certainly do better. And oftentimes what I hear from patients is, why aren't things moving faster? We haven't necessarily had a new drug approved in the last year, and for a while melanoma was boom, 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 boom. So I feel the frustration of the patients, and I think sometimes I want the field to move faster. I want our studies to accrue faster and results to get published faster. But exactly what was said, that we want good science to go out there. We want to make sure we're doing the right thing by the patient. So. With that, I think we'll wrap things up, and I just want to thank all the members of the panel and the patient in the audience and from online and present for asking great questions, and hopefully it was educational.